Good afternoon, good afternoon everyone. So let me cover some of the surgical macular conditions and how to prepare an algorithm for management of such cases. So I'll be covering some of the commonest surgical conditions one tends to see. Either it could be form of a full thickness macular hole or lamellar hole, ERM, vitreomacular traction, myopic tractional maculopathy and subretinal hemorrhage. When you see a case of a full thickness macular hole, either you look at the age of the patient, the duration of the macular hole, the presenting best corrected visual acuity, what could be the etiology of the the full thickness macular hole. Obviously, looking at the spectral domain OCT features and the prognostic indices like macular hole indices, which I will be discussing one by one. The SD-OCT basically helps in diagnosis, staging, prognosis, assessing the tractional forces, either tangential or anteroposterior tractional, and monitoring the closure, whether what type of closure has occurred post-surgery. Hole size is a very critical factor. As we know, the lesser the size of hole, which is less than 400 microns, tends to have a better prognosis than the large size holes, which tends to have a poor prognosis. Many biomarkers have been studied on a full thickness macular hole. Some of the important thing being the mean linear diameter, basal diameter, height, the configuration of the hole, whether it has got a flat edges or the presence of subretinal fluid, what we call as a macular hole angle. Then there is a vitreomacular traction, epiretinal membrane. Look at the external retinal layers also and the supra-RP granular deposits. Many indices have been considered, among them the most important being the tractional hole index, then the macular hole index and the mean lid diameter. I'll be telling in the subsequent slides. But the key thing about these indices is some of the indices looks at both the tractional forces, the tangential and anteposterior, some into some of them. Among them, the most important one are the hole forming factor and the macular hole indices, which takes into account both the tractional forces and as well as the anterior posterior as well as the tangential, which gives a better prognostic value when compared to the other indices. Similarly, the macular hole imaging thing, if you incorporate an image software, we can calculate something known as total area. This is a total area and this is a macular area, the tissue area. And even you can calculate the cystoid area. Based on that, certain indices can be calculated like macular total area index, macular area index, and the cystoid space area index also can be calculated, which has got a prognostic value. Some indices helps in detecting the type 1 closure and some in the type 2 closure. The macular hole indices, tractional hole index, macular cystoid space area index basically very well correlates with the type 1 closure. The opening diameter hole index and the macular area associated indices helps in prognostication type 2 closure. Please look at this photograph. The external retinal layers are very, very critical for the prognostic point of view. Like this, it has got a very good closure with the retention of all the external retinal layers. This patient tends to do well, and compared to these patients, in spite of closure, they may not do well because of the atrophy of the external retinal layers. The microperimetry is another important thing which helps in assessing the retinal sensitivity in these patients. So one need to look at the functional assessment also rather than the anatomical closure. Octa, definitely studies have shown that there is a significant correlation between vessel density of the superficially capillary plexus and the deep capillary plexus with respect to the visual acuity as well as the retinal sensitivity at 1 year. FSZ enlargement may be a potential biomarker for foveal reconstruction after foveal full thickness macular hole, but sometimes the FSZ evaluation may be difficult, especially because of the presence of the intraretinal cyst. But FSZ also can give a clue to the prognostic aspect of the closure of the surgical techniques. There are many surgical techniques have been described based on the size of the holes. The ILM peel and ILM flap works for the mild to moderate sized holes. The macular hydrodissections, human amniotic membrane and autologous retinal transplantation works for the larger sized holes. ILM peeling, definitely ILM peeling works well for the small to medium sized holes. ILM flaps also can be considered for larger holes, but one need to look at if somebody has got a macular hole index of less than 0.5, larger ILM peel should be done for a better outcome of the surgery. As we know, the things like human amniotic membrane and autologous retinal transplantation may give a good anatomical success. Sometimes the best corrected visual acuity may not be as good as, and the functional recovery may not be good, but you may get a good anatomical recovery. So coming on to the surgical algorithm, when you see a case of a full thickness macular hole, what all things to be considered? One is the size of the hole, as I told. The other thing, you can consider the axial length into the thing. Then whether it is a first operation or a re-operation, one should see. Sorry. If it is a re-operation, please see whether it is a fluid cuff at the lifted edges or the flat edges, which gives a clue what should be the management procedure. If there is a fluid cuff is there, then the office fluid gas exchange may help in the closure of the hole. If it is the flat edges, some can do in perifoveal hydrodissection. So if there is a larger axial length is there, probably one can resort to an aggressive maneuvers like scleral imbrication or a macular buckle. But large sized holes, ERT and amniotic membrane works well. Coming on to the lamellar hole, there are two sorts of lamellar hole. Basically, one is called tractional lamellar hole, the other is a degenerative hole. In a tractional lamellar hole, there is a split typically seen at the level of outer plexiform and outer nuclear layer. These patients, if they are symptomatic, may sometimes respond to the surgical treatment. Unlike degenerative holes, which may associated with lamellar hole, epiretinal proliferation and other, these tends to do poorly when compared to the tractional holes. So surgery can be considered in lamellar holes if there is a moderate to severe visual impairment. If there is a metamorphopsia and the outer retinal layers are intact, one can consider, especially in tractional holes, surgical maneuver. Coming on to the ERM, consider the age of the patient. The younger the patients better. Pseudophakic patient does better than the phakic patient. Low baseline visual acuity is a poor prognostic factor. Less than 1 year they tend to do well. The metamorphopia score definitely tends to correlate with the visual acuity. In the ERM, basically look at the stage of the macular hole, which indicates there is an entity which has been described as a ectopic inner foveal layers and the retinal layers. These two entities, if they are present, it indicates a poor prognosis. So stage 3 and stage 4 holes responds poorly to treatment when compared to the stage 1. Suppose the contour of the macula also, if you tend to see a dome-shaped macula, they tend to do well when compared to the flat or a depressed macula. Look for the pit contour recovery post-surgery, which gives a clue. If you have got an early pit recovery for contour recovery, they tend to do well when compared to the other patients. Another entity which has been described, what is known as inner retinal irregularity index, which is also a surrogate marker which tends to correlate with the visual acuity and metamorphopsia score. So one need to look into that. As I told before, the most critical entity in ERM surgery is ectopic inner foveal layer. If you tend to see in presence of an ectopic inner foveal layer with advanced stages, they tend to do poorly, especially in stage 3 and stage 4 holes. I told, look at the outer retinal integrity, not only the inner retinal integrity, they also seems to correlate with the visual acuity. Central bokeh abnormalities is another abnormalities which tends to see in all sorts of tractional maculopathy. They also correlate with the worse visual function if you tend to see along with the ectopic inner foveal layer. The drill is another entity which is seen in other many conditions like diabetic macular edema and all. This is also another surrogate marker in ERM surgery. Shorter the axial length associated with ERM tends to do poorly when compared to the longer axial length. If you tend to see a microvascular leakage associated with an ERM or an FFA, they tend to do poorly when compared to the eyes which doesn't have a microvascular leakage. OCT angiography, definitely foveal and parafoveal vessel density is a positive prognostic factor for post-op visual acuity and macular sensitivity. Some cases, post-surgery, you may not see a typical FSZ expansion post-surgery. These patients tends to poorly in spite of a removal of the ERM. Choroid, if you look at the saddler layer perfusion is one of the prognostic factors which have been shown to be associated with good functional recovery. So as I told with ERM surgery, older the age, longer the duration of symptoms, lower the presenting visual acuity, higher the metamorphopsia score, thicker the central foveal thickness, thicker the ganglion cell layer, and the inner nuclear layer thickened, and the photoreceptor outer segment if they are shorter, ellipsoid zone being irregular, and the presence of ectopic inner foveal layer, all these are poor prognostic factors when you're considering an epiretinal membrane surgery. Coming on to the vitreomacular traction, usually the end sequence of vitreomacular traction is either by spontaneous recovery or they progress to a full thickness macular hole. And what are the poor prognostic factors in a VMT or vitreomacular traction? One is the longer duration, preoperative best corrected visual acuity of less than 660, preoperatively thick central macular thickness, somebody who has got an associated premacular fibrosis, associated schisis and CME. These are the poor prognostic factors in VMT. So if you see a VME, you can just observe. If you see a VMT with asymptomatic and every 3 months you can follow up. If there is a associated ERM which is a thin ERM with a less than 1500 microns, can sometimes respond to the pharmacological vitriolysis. But with EMT and with ERM, if there is present and if the ERM is more than 1500 microns, you need to resort to a surgical maneuver rather than doing a pharmacological or an observation maneuver. Last entity, there is a myopic traction maculopathy. Either you tend to see a schisis or a macular associated detachment or macular holes. So what are the treatment options for myopic traction maculopathy? Either you observe or do a maculobuccal or a pars plana vitrectomy or
Sunil,
scleral
can you
implication.
just wind up,
I'll
please?
find up, okay. Okay. So if you see stages of the myopic tractional maculopathy, if you see a stage 1 and most of it is observation, and stage 2 end stages you may have to resort to maculobuccal or pars plana vitrectomy along with the ILM flaps. Maculobuccal does do well in cases of stage B holes in the myopic tractional maculopathy. And the last thing about subretinal hemorrhage, look at the duration of the submacular hemorrhage, look at the etiology of the submacular hemorrhage and the size of the submacular hemorrhage. If it is a small submacular hemorrhage, you can give an anti-VEGF alone. If it is a medium, you can use an pneumatic retinopexy in the form of expansile gas along with the TPA and anti-VEGF. If it is a medium, you can do a pars plana vitrectomy with subretinal TPA. And if it is a massive, probably external drainage and the displacement with the residual hemorrhage and the intravitreal TP also can be combined with this. So you have to plan the subretinal hemorrhage according to the size, duration and the age of the patient and the etiology of the patient. Thank you. Thank you for your patience.
Thank you, Dr. Sunil, for that extensive algorithm. We're short of time, so concluding the session, I'd like to thank everybody for being here and thank our next chairman, moderator for the patient zone. Thank you.